there is no habit that cannot become excessive, compulsive, and sometimes life-endangering. And there are more and more habits that become addiction. I will talk about DSM and ICD classification of what is called compulsive sexual behavior or hypersexuality or sexual addiction, depending on who is talking about it. The clinical characteristic of compulsive sexual behavior. I would say a few words about chemsex, which is gradually spreading all over the world. Then I will talk about the pharmacological treatment available and the guidelines we recently proposed with the World Federation of Societies of Biological Psychiatry, and then I will come to conclusion. So what about the classification? The DSM-5 did not agree on anything about hypersexuality, and they considered that there were no current hypersexual disorder diagnoses possible due to insufficient evidence to classify it. So they think it's more related to addiction model, but they did not conclude. Concerning the WHO classification, interestingly, they consider it's an impulse control disorder, but they called it compulsive sexual behavior disorder. The definition is quite old because it relies on epidemiological studies conducted in the 1950s in the US. And it's now considered that a persistent total sexual outlet of 7 or more orgasms per week for at least 6 consecutive months after the age of 15 years are considered hypersexuality, which means just that they are at the end of the Gauss curve. That's it. But in fact, it's when you cannot abstain for sexual activity, even when it's not appropriate or if it has some social or professional consequences, which is more adequate as a definition. The prevalence is higher and higher. It's even 7% in women and at least 10% in men. And it might be higher in people with AIDS or in paraphiliac subjects, which means people with deviant, in a certain way, sexual behavior. Sexual addiction or hypersexuality or compulsive sexual behavior concern normophilic sexual fantasies, arousal, urges, and behaviors. It's just a matter of frequency. It might be continuous or episodic under the influence of stress or substance abuse, for example. What about the clinical characteristic of these people? The age of onset is usually adolescence, but there is a shame, and usually the mean duration before diagnosis is 12 years, which means that people are suffering a lot, in most cases, for 12 years without saying anything to anyone. And usually patients are referred to psychiatrists for suicide attempt, depressive or anxiety symptoms, but rarely for addiction to sex. Sexual dysfunction is also quite often observed with erectile dysfunction in 20% of cases. And the duration, frequency, and intensity of these behaviors is associated with significant personal distress and impairment in 3/4 in a cohort of 350 men. There is a high level of psychiatric comorbidity, especially mood disorders, anxiety disorders, and mostly, and surprisingly, social phobia. Substance abuse, especially alcohol abuse, is often observed in 3/4 of cases. Cannabis, cocaine, poppers abuse can also be associated. And interestingly, ADHD is often associated. And we think that in men with high levels of hypersexuality and pornography use, ADHD should be systematically assessed. Impulse control disorders, other addiction are less frequent, such as compulsive buying in women, and OCD is very rarely observed. Personality disorders are frequent, but all types of personality disorders without an overrepresentation of borderline of antisocial. What about the relationship between sexual addiction and paraphilia? Sexual addiction might become a paraphilic disorder, especially when people cannot resist exhibiting and masturbating at work or in front of other people, for example. Or they can forget to ask for consent to a sexual partner because they have a huge craving, and that might be called rape, of course. So in a cohort of 47 hypersexual men, compared to 38 control men, paraphilia like exhibitionism, voyeurism, masochism, sadism, fetishism, frotteurism, or transvestism were more prevalent in men with hypersexual disorder, almost 40% as compared to 3%. Men with hypersexual disorders were also more likely to report sexually coercive behavior, 70% versus 20% in controls. And they also have a higher rate of having consumed images of child abuse at least once in their life, 91% versus none in controls. What types of hypersexual behavior? Of course, sexual fantasy doesn't cost anything. Compulsive masturbation doesn't cost anything. 1/3 to 3/4 excuse me, of people. Voyeurism, anonymous sex with prostitutes or via internet, multiple sexual partners, 40 to 60%, and sometimes paying partners, which costs them a lot of money, and they lack money because they spend all the money to pay for partners, different partners. Cyber pornography, half of them. 6 to 9% of men using internet use it more than 1 to 2 hours per day. At-risk sexual behavior, which is a huge problem concerning AIDS, hepatitis C, for example, which is increasing, especially because of this patient who doesn't pay attention to risky behavior and to infectious risk. And concomitant use of illicit substances, which might be used in chemsex parties and which might be associated to addiction to new substances. Coming now to chemsex. Chemsex is just a small part of hypersexual behavior, and it might not be related to hypersexual behavior. So it's just a special concept. Chemsex behavior means use of specific drugs before or during planned sex to facilitate, initiate, prolong, sustain, and intensify sexual activity. Certain drugs have been associated with chemsex. In the past, it was alcohol or cannabis. Now it's more synthetic catechins, methamphetamine and crystal methamphetamine, GHB, or its prodrug, GBL. Cocaine and ketamine were also associated, but the type of drug used during chemsex depends very much on the country concerned. Poppers are also widely used. The prevalence of chemsex is high, especially in men having sex with men, until 1/3 of them. But it's gradually spreading in general population, and we found recently in a French student population that more than 20% of them were using substances during sex. What kind of pharmacological treatments can be used in combination with psychotherapy? Patients seeking treatment are often motivated by legal issues, for example, exhibitionism or rape, marital or work-related problems, psychiatric or somatic comorbidities. They may also refer to psychiatrists after a suicide attempt or because they present symptoms of another psychiatric disorder. So do not hesitate to ask the question about sexual addiction when you see a patient for any reason. The pharmacological treatment aims are to reduce compulsive sexual fantasies, urges, or behaviors, to enhance self-control over compulsive sexual behavior, to treat co-occurring psychiatric and especially addictive or somatic, such as infectious diseases associated. In case of chemsex, control chemsex behavior and use of illicit drugs. And in case of co-occurring paraphilic disorders, it's to reduce the risk of sexual offending. In some patients, sexual fantasies, urges, or behavior may be so intense that psychotherapy alone is not sufficient to reduce psychological distress. So in this patient, additional pharmacological treatment may be necessary. And finally, being neglected or sexually abused as a child are significant factors that might be associated with compulsive sexual behavior, and some studies describe them a past history of sexual abuse in 80% of people with compulsive sexual behavior disorder. So specific psychological treatment for physical or sexual trauma is an essential component of treatment. SSRIs. They are not formally approved for compulsive sexual behavior, but they have been included in numerous cases in clinical practice off-label. There are only 2 randomized control studies, but there is further clinical evidence with open studies and numerous case reports that all SSRIs reduce compulsive sexual behavior with a reasonable benefit risk. We consider it as a level B of evidence. SSRIs may also be mostly be interesting in patients with compulsive sexual behavior disorder with comorbid depressive anxiety or obsessive compulsive disorders. In this case, it works very well. Naltrexone. So not formally indicated, it has been also included in clinical practice off-label. There is 1 randomized controlled trial and few control studies, and also clinical evidence that naltrexone may reduce compulsive sexual behavior with a reasonable risk-benefit ratio with a level B of evidence. So when can you use naltrexone? Naltrexone may be especially suitable when patients with compulsive sexual behavior disorders have co-occurring addictive disorders, substance addiction as well as behavioral addiction. What about our guidelines? So in the first part, we will consider compulsive sexual behavior disorder without chemsex and without paraphilic disorders. So it might be freely downloaded through the WFSBP website. So according to the level of severity of compulsive sexual behavior disorder, mild to moderate, psychoeducation to prevent unwanted pregnancy, sexually transmitted infection, and to educate about the risk associated with compulsive sexual behavior, and especially rape and infectious diseases. Motivational interviewing might be used to increase observance. Psychotherapy, especially cognitive and behavioral therapy, or acceptance and commitment therapy, which is a new way of practicing CBT with a level C of evidence. Treatment of co-occurring depressive or anxiety disorders or other psychiatric disorders, if any. And finally, reduce level of stress and impulsivity, and improve self-esteem with CBT or ACT. In case of moderate compulsive sexual behavior, 2 cases: presence of co-occurring depression, anxiety disorder, especially OCD ideas prefer SSRIs. The dosage, in addition, of course, to psychotherapy, with the dosage gradually increase at the same level as dosage used in OCD. Sertraline 50 to 200 milligram per day, fluoxetine 20 to 80 milligram per day, or even paroxetine 20 to 60 milligram per day, level B of evidence. In case of association of compulsive sexual behavior with co-occurring alcohol or substance misuse or other addictive disorders, use naltrexone 50 to 200 milligram per day with a level B of evidence in conjunction with psychotherapy. And in case of severe compulsive sexual behavior, you can combine naltrexone, same dosage, to SSRIs and psychotherapy. Other psychotropic drugs such as topiramate, nefazodone, psychostimulants can be used in specific cases, but there is no level of evidence. CPA or GnRH agonist treatment, such as hormonal treatment, should be reserved for patients with intense CSBD symptoms and co-occurring paraphilic disorders with at least moderate risk of sexual offending. And finally, we have published recently a paper of the efficacy of non-invasive brain stimulation techniques in 1 case in an open study. In case of CSBD with co-occurring paraphilic disorders, mainly pedophilia, exhibitionism, or sexual sadism, we may use CPA or GnRH agonist, and please refer to our previous guidelines on the treatment of paraphilic disorders, which are also on the WFSBP website, freely available. And in case of CBD associated with chemsex, careful search for co-occurring psychiatric and somatic disorders, somatic and psychiatric consequences of alcohol, illicit drug, and chemsex practice. In all cases, psychoeducation is important to reduce the risk for alcohol and or illicit drug intoxication and related adverse effects. Reducing non-consensual sexual behavior, which is very often associated with chemsex practice, as well as sexual violence, which is a huge problem with chemsex practice. Promotion of rapid self-tests to search for sexually transmitted infection, informing about PrEP and post-exposure prophylaxis availability. In case of illicit drug disorder, there are no guidelines for the management of methamphetamine, ketamine, synthetic catenon, GHB or GBL use disorders until now, unfortunately. In conclusion, the conceptualization of hypersexuality remains poorly understood. The risk of deviant sexual behavior is also poorly known, associated with compulsive sexual behavior. The association of psychotherapy and pharmacological treatment is the most effective approach, and there is, of course, a need for well-designed pharmacological studies and increasing knowledge about what is really compulsive sexual behavior. So these are our recent guidelines. We have written several reviews about chemsex, sexual addiction again, and psychotherapy treatment of sexual addiction. And finally, we will organize the next World Congress of Women's Mental Health in 2025 in Bangalore, India. And we'd like to thank you very much for your attention. Thank you.